In this part, we'll discussing the remaining topics, that is clinical findings, that is sign and symptoms, lab findings, complication, and treatment. And now the sign and symptoms. In case of autoimmune thyroiditis, typically involve the immune system attacking the thyroid gland and lead to hypothyroidism. Sign and symptoms are mostly related to the level of thyroid hormones. Affected patient may have combination of both hypothyroidism and hyperthyroidism symptoms. For example, a patient with hyperthyroidism might later develop hypothyroidism and vice versa. In early phase, the symptoms may be mild or even absent. Rarely in the early phase, there may be a short period of mild hyperthyroidism, that is overactive thyroid gland, with symptoms such as palpitation, anxiety, sweating, and heat intolerance. However, this phase is usually brief and less common. If present, then after a short period, it followed by a stage of hypothyroidism. The common signs and symptoms of hypothyroidism are the increased sensitivity to cold, unexpected weight gain, constipation, dry skin, hair loss, heavy or irregular menstrual periods, depression or mood changes, fatigue, and sluggishness. The signs and symptoms can develop slowly and vary in severity. In case of painful subacute thyroiditis, the hallmark is the pain in front of the neck, often radiated to jaw and ears. The thyroid is tender to touch and may be swollen. In case of infectious or suppurative thyroiditis, the pain in the neck is often intense, localized, and may be associated with redness and warmth over the thyroid. Marked fever, chills, and signs of sepsis are common, reflecting a bacterial infection. Dysphagia and voice changes may occur due to local inflammation. No typical thyroid hormone dysfunctions, unlike subacute thyroiditis seen in case of infectious thyroiditis. In case of IgG4 thyroiditis, the thyroid gland becomes stony hard and adherent to the neck structure, causing signs of compressions including dysphagia, dyspnea, and hoarseness. There is no pain. The hypothyroid feature is present. There is thyroid hormone deficiency that persists even after the treatment, and also requiring a long-term thyroid hormone replacement treatment. Complications in case of autoimmune thyroiditis, it may lead to either hyperthyroidism and more commonly the hypothyroidism. The hypothyroidism is due to the release of stored thyroid hormone, and this may be the initial phase for very short period of time, then followed by the hypothyroidism. Women with increased level of antithyroid peroxidase antibodies but euthyroid have increased risk of miscarriage, preterm birth, and unfortunately the treatment with the levothyroxine fails to improve these risks. In perimenopausal women with increased serum antithyroid peroxidase antibodies have high risk of depression independent of ambient thyroid hormone levels. In case of subacute or chronic thyroiditis are complicated by the effect of pressure on the neck structure, for example dyspnea. And in case of renal thyroiditis, there may be a chances of vocal cord palsy. Then ultimately the papillary thyroid carcinoma or thyroid lymphoma, rarely associated with chronic thyroiditis, must be considered in the diagnosis of uneven painless enlargement that continue despite treatment. Such patients require FNA biopsy. And now the lab findings. In case of Hashimoto thyroiditis, the TSH is increased, free T3 and T4 is decreased when the disease is established, that is hypothyroidism. And this TSH and T3 and T4 levels may be normal in the early phase of the disease. Antibodies, anti-TPO antibodies are present, and anti-TG antibodies, that is thyroglobulin antibodies, are present in some patients. And in case of postpartum thyroiditis, in postpartum thyroiditis typically involving a biphasic pattern, that is in first there is thyrotoxic phase. In case of thyrotoxic phase, there is low TSH and high T4 and T3 levels, and later followed by the hypothyroid phase, that is TSH is increased and T4 and T3 levels are decreased. The thyroid function test vary with phase. TSH can be below 0.3 ml in thyrotoxic phase, or it is above the 3 ml in phase of hypothyroidism. The antibodies, often anti-TPO antibodies, are present in case of postpartum thyroiditis. In case of painful subacute thyroiditis, the initial hyperthyroid phase is later followed by a hypothyroid phase. In case of hyperthyroidism phase, there is elevated level of free T3 and T4 and TSH level is low, whereas in case of hypothyroid phase, the T3 and T4 level is on lower side and TSH is elevated. ESR is markedly elevated, CRP is also elevated, WBC is often elevated and show raised neutrophils or may have leukocytosis. Also, thyroid antibodies are usually absent. In suppurative thyroiditis, the TSH, T3 and T4 level is usually normal. WBC shows significant leukocytosis. ESR and CRP, that is inflammatory marker, are elevated and the blood culture is positive if bacteremia present. In case of silent or painless thyroiditis, the initial thyrotoxic phase is then followed by the hypothyroid phase. The similar features that we discussed in the previous types, the antibodies may be present, that is anti-TPO antibodies. The WBC, ESR and CRP is normal. So in summary, in case of Hashimoto thyroiditis, the TSH is elevated, free T3 and T4 are low. Antibodies, that is anti-TPO antibodies and anti-TG antibodies, are increased. There is no inflammatory markers and WBC is normal. Also, in case of subacute thyroiditis, in early phase there is decreased TSH and increased level of free T3 and T4 level, suggestive thyrotoxic phase. And in later phase, the TSH is elevated and T3 and T4 level are low, suggestive of hypothyroidism. The antibodies are usually negative. Inflammatory markers, that is ESR and CRP, are elevated and WBC is also increased. Same in case of silent thyroiditis, that is in early phase there is decreased TSH and increased T4 T3 level. In late phase there is increased TSH and decreased T3 and T4 level. There is mild increased level of anti-TPO antibodies. There is no presence of any inflammatory markers. WBC is also normal. In case of suppurative thyroiditis, the TSH and T3 and T4 level is usually normal. There is no antibodies present. The ESR and CRP, that is inflammatory markers, are elevated and also there is increased leukocytosis. And lastly, in case of postpartum thyroiditis, there is same increase in TSH and T3 and T4 levels in early phase and increased TSH and decreased T3 and T4 levels in later phase. The anti-TPO antibodies are also elevated and inflammatory markers are normal and WBC is also normal. At last is treatment. In case of Hashimoto's thyroiditis, the primary therapy is a lifelong thyroid hormone replacement with levothyroxine to treat hypothyroidism. Dose adjustment is based on the TSH levels. No therapy may be needed if thyroid hormone remains normal or in subclinical phase. No role of steroid unless there is Goitres pressure symptoms. In case of subacute thyroiditis, the mild case NSAID, for example ibuprofen or aspirin, are the first line of treatment. In severe case, we can use the prednisone 15 to 30 ml per day, tapered over a few weeks. If there is thyrotoxic phase present, the beta blocker, for example propranolol, to manage the symptoms, for example palpitations, anxiety and tremors. The thyroid hormone replacement is rarely needed, but if hypothyroidism is severe or prolonged, temporary levothyroxine we can use. Note, this is self-limited and resolve over week to months. In case of postpartum thyroiditis, mild case, no treatment required, just monitoring of thyroid function tests. In overactive phase, the beta blocker for the symptomatic controls, the anti-thyroid drugs are not used, as hormone release is the problem, not the hormone synthesis. As in case of overactive phase, the stored hormones are released into the circulation and there is no increased synthesis of hormone. So no use of anti-thyroid drugs. In case of hypothyroidism, the levothyroxine, only if prolonged hypothyroidism, can be tapered off if thyroid function normalized after several months. Breastfeeding. Both beta blocker and levothyroxine are considered safe in breastfeeding. In case of infectious thyroiditis, the aggressive IV antibiotics based on likely or culture of organism is mainstay of treatment. Example, amoxicillin and clavulanic acid is common in case of children's. Surgical drainage of the abscess if present. Avoid fine needle biopsy during the active infection. And in case of silent thyroiditis, usually self-limiting, beta blocker in hyperthyroid phase and levothyroxine if prolonged hypothyroidism. Avoid anti-thyroid medication. Example, methimazole, propylthiouracil are not effective since hormone excess is from release, not synthesize. If this thyroiditis is drug induced, then stop or reducing the offending drugs if possible. And in case of renal thyroiditis, the drug of choice is tamoxifen, 20 mg only, BD and continue for years. Tamoxifen inhibits the transforming growth factor beta, the key cytokine that promotes fibrosis. Corticosteroid for pain management. So in summary, in case of Hashimoto's thyroiditis, the first line treatment is lifelong levothyroxine and adjust dose based on TSH, or rarely NSAIDs or steroid used in case of Hashimoto's. In case of subacute, NSAID is the first line treatment, and if severe, the corticosteroid we can use, and additionally beta blocker for symptomatic treatment and levothyroxine for hypothyroidism. And in case of silent, usually self-limiting not required in treatment, but beta blocker if needed, and additionally temporary levothyroxine in hypothyroid phase. In case of acute suppurative thyroiditis, the IV antibiotics, drainage if abscess is present, surgery if severe or recurrent, and in case of postpartum thyroiditis, beta blocker in case of hyperthyroid phase and levothyroxine in case of hypothyroid phase, usually self-limited, safe in breastfeeding. And lastly, in case of renal thyroiditis, tamoxifen is the first line of treatment and corticosteroid if the pain is present. Note, most forms except Hashimoto's are usually self-limited. Hypothyroid phase is in subacute, silent, and postpartum thyroiditis are frequently temporary, but follow-up is essential to rule out persistence. No antithyroid drugs are used in thyroiditis related thyrotoxicosis because it is due to leakage, not increased synthesis of thyroid hormone. Monitor TSH every 6 to 8 weeks during recovery phase.